My name is Dr. Gary Orr and I'm a retired consultant psychiatrist. I'm here to talk to you today about my own personal journey through burnout, recovery, rehabilitation, and the redevelopment of my professional identity in a new life as a designer and healthcare consultant. My personal journey began when I was working on an acute adult inpatient service, which was characterized by many of the attendant problems that all of you will be only too familiar with in terms of heavy caseloads, complex clinical problems, being on an adult acute inpatient service, which was complicated by high levels of violence and poor resources, both in terms of high staff turnover and also in terms of the actual physical environment that we were working in and expected to care for patients in. All of these are recognized as significant risk factors for burnout amongst psychiatrists. Unfortunately, my own personal journey was complicated by a vexatious and prolonged clinical complaint and formal investigation, which lasted for over 3.5 years. What we do know is that the more protracted and prolonged an investigation process is, the more personally damaging the outcome can be for the individual clinician concerned, regardless of whether or not they were exonerated through the process. Fortunately, I was exonerated through the process, and the outcome resulted in significant findings of systemic issues against the institution concerned. However, my own personal experience was characterized by not only feelings of extremely high work stress, but also experience of symptoms of depression, anxiety, and an increasing sense of alienation and isolation from my colleagues. At times I felt unsupported by both colleagues and also scapegoated by the hospital system. We know that these experiences will further complicate any burnout process and the personal consequences for the individual clinician. This process is very well documented by Bourne et al., who document the personal process as negative outcomes for doctors experiencing medico-legal complaints, and my own experience echoes many of these findings. One of the consequences of a protracted clinical investigation is that doctors are at increasing risk of engaging in defensive practice characterized by increasing use of investigations and arguably over-investigation, over-prescribing, and increased requests for second opinions. These factors all place additional economic and resource limitations on healthcare services. We also know in many cases where there has been a complaint against an individual, the process of investigation can uncover issues of systemic dysfunction, leading to findings against an institution rather than the individual practitioner concerned. Very often a senior clinician can be seen as the personal embodiment of the service and therefore can be the subject of a complaint, where in actual fact the issues are of a more systemic nature within the service or the institution. Additional research shows that practitioners can experience increasing feelings of isolation, alienation, and a loss of professional identity, with a growing sense of dissatisfaction of their chosen career. My own experience mirrors this. And this ultimately led to me choosing an alternative career from medical practice. Once my name had been cleared by the investigation, I then made the decision to leave clinical practice and experienced a significant sense of relief when I had made that decision, and realized that I was able to begin to function autonomously again, independently again, and exercise my own route to self-determination. And this is one of the tenets of what Dave and I are trying to communicate, is whether or not burnout can be seen as a gift of discovery, as a gift of revitalization, relearning, and re-establishing one's new identity after the process of burnout. I would argue that burnout is an ongoing process of recovery, learning, rehabilitation, and learning how to live within the confines of a post-traumatic recovery process. And I think this is still ongoing for me. My personal journey began after an initial period of travel, rehabilitation, recuperation. I then engaged in an extended program of personal self-care, which included a fairly rigid regime of personal training and exercise, meditation, and yoga. During this time, I also began to reformulate an alternative professional identity, and I chose to go off and study interior design and commercial design. And this began a freeing up of a creative internal dialogue within myself, allowing me to set up a design practice in Australia. And now, 4 years later, I am beginning to branch out back into healthcare consultancy, and I have forthcoming speaker engagements on both television and conferences where I'm appearing to talk about the process of burnout and the management of burnout. On reflection, experiencing burnout is at once a terrifying and destructive experience, but it can also be an opportunity for learning, growth, and personal development. We know there are multiple contributory factors to burnout, and hopefully this synopsis has shown a number of those factors as borne out through my own personal experience. What I would like to leave you with are a number of questions. Is burnout an individual or institutional responsibility? Is burnout avoidable, or is it part of contemporary healthcare practice? And how can we shift from burnout being an individual problem to burnout being an institutional concern? And I think this is really important, because burnout as an institutional concern recognizes that the cost to society of training an individual healthcare practitioner is significant. So surely we should be shifting healthcare services to not only taking care of patients, but also taking care of those people that work in the service, so that they are better suited to being able to exercise care of the people who come to see them to the best of their ability, in the knowledge that they are supported by the service. Thank you for listening, and I hope you have found this useful.